Hi, I'm Dr. Monty Pal, your host of the ASCO Daily News Podcast, welcoming you to our special coverage of the 2026 ASCO Annual Meeting. I'm a medical oncologist, professor and vice chair of academic affairs at the City of Hope in Los Angeles. I'll be sharing my takeaways on selected abstracts from day 2 of the meeting. My disclosures are available in the transcript. Now, today I've selected a couple of abstracts that feature really important practice-changing data on the treatment of renal cell carcinoma. We've got some advances in ER-positive, HER2-negative early breast cancer, and also the use of olanzapine as an effective steroid-sparing alternative for chemotherapy-induced nausea and vomiting for children and adolescents. Now, we're going to start with abstract LBA 4511. This is the so-called Rampart study presented by James Larkin. This was exciting data that we actually first saw at ESMO last year, and this is in the field of kidney cancer, which is near and dear to my heart. This particular trial evaluated 1 year of immune checkpoint inhibitors versus active monitoring in patients with high risk of recurrence. These are patients with a Leibovitz score that classified them as being intermediate or high risk. It also included patients who had resected metastatic disease. There were 3 arms on this study, and prior to this meeting, we only heard about 2 of them. With respect to those 3 arms, Arm 1, as mentioned previously, was just active monitoring. Arm 2 was 13 cycles of therapy with durvalumab. And Arm 3 was actually durvalumab plus tremelimumab. Patients got 2 doses of tremelimumab from the get-go. In this study, there was real intent to see whether or not perhaps one could get away with just monotherapy with durvalumab in this case. What we ultimately saw from the data, I thought, was really fascinating. When we do a comparison of the third arm versus the first arm, so again, that's doublet therapy versus active monitoring, we saw that there seemed to be a very significant benefit in terms of disease-free survival. And that really held with the investigators' most recent analysis. On the other hand, if we look at durvalumab just by itself, and really that's kind of akin to what we're doing in the context of therapy as standard of care with pembrolizumab these days, we saw that there was a 26% relative reduction in the hazard of disease recurrence or death, but conventional statistical significance was not reached. The hazard ratio was 0.74, but that one-sided p-value was 0.041. 3-year DFS was 78% with durvalumab monotherapy versus 72% with active surveillance alone. So the authors very nicely summarized here that, as they observed previously, the combination of durvalumab with tremelimumab was associated with a statistically significant improvement in disease-free survival, but this was not seen with durvalumab therapy. So there's something unique, I think, about regimens that we've looked at, for instance, in KEYNOTE-564 with pembrolizumab monotherapy that really still constitute an existing standard. I'm going to shift gears now, and we're going to discuss a study in breast cancer. So this is abstract 500, presented in the oral abstract sessions today. These represent the first results from the OPTIMA phase 3 randomized non-inferiority trial of test-directed chemotherapy in patients with higher clinical risk ER-positive, HER2-negative early breast cancer. So that's a mouthful. But let's talk for a moment about the OPTIMA test. The OPTIMA test, which represents an optimal personalized treatment of early breast cancer using multi-parameter analysis, is actually a test that incorporates the PAM50 gene expression test. Now, in this particular clinical trial, women and men, importantly, who were age greater than or equal to 40 were recommended to receive chemotherapy for ER-positive, HER2-negative early breast cancer with 0 to 9 involved nodes and a tumor size of greater than 30 millimeters were eligible. Randomization was between standard chemotherapy followed by endocrine therapy or to a ProSigna test with directed chemotherapy decision. Now, this is really interesting. If you had a ProSigna score that was greater than 60, you were assigned to chemoendocrine therapy. But if you had a low score, this was something less than or equal to 60, you were randomized to just endocrine therapy alone. From the time of initiation of this study, there were a total of 4,429 patients randomized. Ultimately, there were 2,215 that were randomized to the control arm, and 2,214 actually got the test-directed arm. Now, in this particular study, what they ultimately observed was quite interesting. They saw that in patients who had received this test, they essentially were able to discern patients who did not require further chemotherapy. What they saw is that in this particular study, if you had an ROR score of less than or equal to 60, you could safely avoid chemotherapy. The hazard ratio for benefit here was 0.99, therefore meeting the pre-specified non-inferiority margin. The corresponding 5-year recurrence rates for the low ROR population were 94.9% and 93.7% in this group, again demonstrating non-inferiority. So in this case, we have a novel test here, again, the Optima test, that might potentially discern those patients who can avoid chemotherapy in this high-risk population. So very, very exciting data, very large, robust trial. I love always the international focus of ASCO. So in our last abstract that we cover for today's meeting, and again, exceptional array of abstracts, so hard to choose, we're going to talk about abstract 10,017. This abstract was presented by Dr. Radhakrishnan, and importantly, this was a joint effort across multiple institutes in India. This is a combination of folks from the Apollo hospitals, the Jawaharlal Institute of Postgraduate Medical Education, Max Hospitals, and also the All India Institute of Medical Sciences in New Delhi. This study tackles the issue of supportive care. In this particular clinical trial, they looked at dexamethasone with a 5-HT3 receptor antagonist and a neurokinin-1 agonist, which really constitutes the standard guideline for therapy in this particular setting for chemotherapy-induced nausea and vomiting. This trial randomized patients who were between the ages of 4 to 18 years who were receiving single or multi-day highly emetogenic chemotherapy to receive dexamethasone, palonesitron, and fosaprepitant, or olanzapine, palonesitron, and fosaprepitant alone. Again, this is without dexamethasone. This is a dexamethasone-free regimen. What we ultimately saw in the context of this study, again, one regimen with dexamethasone, one without, is that there really did not seem to be any significant difference between the two arms. It met the threshold for non-inferiority in this trial. And this really offers an opportunity across this fairly large experience with 310 patients randomized to really offer some compelling evidence that in these younger populations, we can potentially get away without using dexamethasone as a part of our antiemetic regimen. So again, very important findings in the context of this study. And again, we have to bear in mind that this study is coming from a low resource setting. It really proves the power of what some of these centers can do, banding together to address really relevant day-to-day clinical questions. So I want to thank everyone for listening today and join me again tomorrow to hear more top takeaways from ASCO26. If you value the insights that you heard today on the ASCO Daily News podcast, please don't forget to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.